we go into detail because we don't want you to get one of these. This is a bad thing to get in the mail. This is a statement of deficiency, and then you have to do a plan to fix it. And the contract management standards are located inside the CMS condition of participation. It starts at tag 83. And how they end up getting into the COP is step 1, they publish them in the Federal Register, and then when they're final, CMS comes along and adds interpretive guidelines, and some of them, not all of them, have a survey procedure. So today we're going to talk first about Appendix A. This is your website, so just click on, hold your browser over A. So if you say, you know, I want to read what tag 85 says, or gee, tag 86 seems kind of interesting, I want to go read it, you'll be able to do that. And then here's the email address that you may email questions directly to CMS. And when you click on it, you will notice that it also says State Operation Manual. That is the same thing, don't be confused. This is the website on slide 7 where CMS publishes any survey memos that, and they expect hospitals to monitor this so as things change in the future. And this is a list of the different survey memos, and when you open it up, you just click on whatever one that you would like. On slide number 9, this is how you can sign up to get the Federal Register, so when there are changes, and we do have 2 proposed laws that would impact hospitals, the proposed hospital improvement rule and also the discharge planning standards. And if and when they're final, they would be published in the Federal Register, so that's how hospitals would know that. And this is the email address, just like you can email, there's a question standard form at jointcommission.org. You can, for the first time, email CMS, and their phone number is on here. And when we talk about the Joint Commission contract management standards, this is also a phone number that you can call and talk to the Standards Interpretation Group. And on slide 11, when you go to jointcommission.org, this is when you click on online question form, because they ask you what manual you're using. The same way if you email questions to CMS, you would want to say, I have a question about, you know, tag number A, you know, 150 or whatever. And then it kind of looks like this. You just kind of fill it out. And we're going to show you some data. CMS has been collecting data and publishing it for hospitals since March of 2013. And in fact, this is on the bottom of 15 is the website where you can get the deficiency data. And this is the most recent report. And for our 3 tag numbers in the hospital manual, which is tag 83, 84, and 85, you can see that we have about 225 tag, deficiencies for these 3 tag numbers. And the reason why hospitals got into trouble is failure to monitor contracted services. The contract didn't have a description of the service. They weren't monitoring the contracted services under QAPI, and we're going to explain all of these in this presentation. The contracted dietitian did not follow the dietary COPs, and the services that are involved often that we will contract out, laundry service. If you ever contract out laundry service, you still want to make sure that they have Healthcare Laundry Accreditation Council accredited by. Security, police officers sometimes are hired to do security for hospitals. The dietitian could be your employee or could be a contracted employee. Interpreters, housekeeping, or environmental services. There were many that related to dialysis, EICU vendors. Here was an RNFA, RN First Assistant contract and they didn't ensure, and their emergency department physicians were independent contractors, and the contract said that the ED physicians had to have ACLS, and they didn't. I know at the hospital that I worked at as legal counsel, if our ED physicians were board certified, we didn't make them have ACLS. If they weren't, then they did. Again, if you outsource pharmacy or outsource some compounding to a freestanding compounding facility. Hospitals didn't explain the scope and nature. They failed to keep a list. We're going to talk about all these. They had no signed transfer agreement. The board did not review contracts or a summary of the contracted services. The board did not make sure that the contracts were performed in a safe and effective manner. This was an agency nurse, and there was no orientation to somebody who was providing contracted services. And CMS calls travelers and agency nurses non-employee nurses. And then you need to make sure that you're having metrics and that the contract is evaluated to ensure compliance. And so again, performance indicators. So I'm actually going to explain all these because these are actually in the CMS COPs. Failed to make sure that all the hospital contracts were on the list. Failed to approve the contract for the maintenance of water treatment and hemodialysis. Failed to ensure that personnel that were providing contracted services, these are agency nurses, were trained, so they didn't know how to call a code or how to call fire, some of the important things that is a requirement also in the nursing COPs. Failure to make sure that the contracted company had destroyed the narcotics. And again, a lot on contract dialysis service. It was not provided in a safe manner, and they didn't do any QAPI, so we're going to talk about all of those. And one of the things, I think it's the reason why we have seen an increase in the number is that in QAPI, for example, we have over 1,600 deficiencies, is that in the QAPI worksheet, they now ask about contract management. So, and we have 3 worksheets. One is on infection control, one is on discharge planning, and one is on QAPI. This is the website, again, if you want to get a copy of those worksheets. But, for example, under the broad QAPI requirements and the responsibilities of our leadership team, it says that you're using information from the hospital to identify the services that are provided by contract. And can we actually show that we've done an assessment related to these? And again, I'm going to give you a lot of examples here. And then before we even get to the tag numbers or section numbers at the beginning, during the entrance activity when the surveyor first comes to the hospital, they tell the surveyor to clarify and ask, okay, hospital, what contracted services are you sending out? And also to make sure that you have a list of the contracted services. And you want to have a list and you want to have them all in one place. One time, gosh, about 15 years ago, I went to be attorney and compliance officer and privacy officer for a small hospital, and the contracts were all over the place. They didn't have a contract log, and they didn't have policies, and so it took a lot of work to get in control of the contract services and manage those. So the first thing that you need to do is have a list, have them all in one place. And so, for example, you want to actually have, what is the contract provider? What services are they providing? So, for example, radiology services, they use somebody in the evening to do teleradiology. And then we have what is their performance measures or quality measures. And then we have somebody who's responsible to make sure that I call them the contract owner. And then we always listed who was over the contract owner. And then we also had the date of the contract. And so, for example, with each of these, you can see what the performance measure was. So for the service that was providing lithotripsy, they measured the number of canceled procedures after the patient arrived, meaning that they hadn't done a good job at doing all the pre-op work before, the total number, cancellation rates, etc. Here is laundry service, videotaping, their blood, Red Cross. They have phone interpreting services and live interpreting services. So, for example, on the telephone service, they would expect them to, they would give them a list of all the languages. And in our phone one, they had to, and I was always amazed at how quickly they got an interpreter on the phone, but our standard was, within 60 seconds. So the bottom line is list all of your contracts, and these are, again, some of the ones that are common contracted services for hospitals. Some hospitals will, and even though I worked at a big hospital, in the emergency department, we would send out our tox. If someone took an overdose, then we would do blood and urine, and we would send it to a local tox place that would, do the screening on that. And so we had a contract. We made sure that they were CLIA certified and some of those types of things. Here's another form where you list what the contract is, what's the scope. So this contract is 32 pages, and it's to provide transcription services. And also during the document review session, they tell the surveyor to, if you do provide any contracted services, again, they want to know about it. And again, they're going to go and make sure that we've done, you know, our QAPI and that we've done our performance measurements, so we're getting, you know, money, you know, we're getting our money's worth or whatever. So if you've never seen what a section looks like out of the CMS manual, the tag number will always be on the upper left-hand side. And the nice thing is that under every tag number, there will be this, there'll be a little thing about when that section was last amended. And so having written for 35 years, either working for hospitals or in a law firm where we worked with our clients that were hospitals, I would write a lot of policies. And I would always say this policy, for example, when I wrote our contract management policy, I said this policy is to comply with, and then, you know, I started with the CMS tag number 83, 84, and 85. And so if I'm gone the next year or someone's reviewing that policy, they can go back and say, oh, well, gee, this particular tag number hasn't changed in 10 years, so this policy is probably still current. So under tag 83, our board, and if you look at all of the CMS COPs taken together, they're ultimately responsible for everything that happens in the hospital. And again, CMS doesn't care whether that contract is performed by your hospital employee or under contract. So one time I went to a hospital to work, and the pharmacist was not our employee. The pharmacist was an independent contractor who worked for the pharmaceutical company that the hospital had hired to run our pharmacy. So you can't say to CMS, well, that, you know, that director of pharmacy is an independent contractor, no skin off my back. Well, yeah, it is, because they don't really care whether it's your employee or contracted. We have 18 pharmacy standards. They a few years ago rewrote 10 of the 18, and they expect you to be in compliance. And also, when we talk about contracted standards, when we come to the Joint Commission ones, they make it clear that this contract management standard is for patient care services. Now, Joint Commission says that there could be other standards, other places that talk about, you know, the roof or whatever, but in their contract standards, it's all about, you know, clinical patient care. CMS, while they primarily look at this, CMS does say that it can include shared services and joint ventures. So, for example, if you hire, you know, if the worked at a hospital one time and the housekeepers or environmental services was contracted out to a company that came in and ran it. Now, the housekeepers and environmental service workers were actually our employees, but it was a contracted service, and the director was, again, an employee of that service. Laundry, lab, pharmacy. And as I mentioned, the difference is that Joint Commission clarifies that they're only talking about patient care contracts, although for the most part, if you go back and you read all the reasons why hospitals were cited, pretty much they're doing the same thing, even though they say it could be for joint ventures and shared services. And the board has to take action under the QAPI program to make sure that that service was done, whether it was by an employee or under direct contract. And sometimes hospitals didn't know this. So, for example, when I came to the hospital and I said to the pharmacy director, who's, again, an independent contractor, have you seen what was in the contract as far as the performance measures, things that you have to make sure you're doing? And the pharmacist said no. They, you know, the contract was between the hospital and my company, but they never shared that with me. And so I said, that's okay, that's why I'm asking. So I took out what were the performance measurements, and then we sat down, I put them in writing to the pharmacist, and I said, in 6 months, we're going to have an informal evaluation, and at the end of 1 year, we'll do a formal evaluation just like we do to all of our employees. And when I used to do contracts, and gosh, even at a small hospital, I know the first year I did 200 contracts, reviewed 200 contracts. But what I used to do is pull out the performance indicators and have them attached to the contract and say the performance indicators are hereby incorporated by reference and are attached as Appendix A. That way, it was so easy just to hand them to, the dietitian who is not an employee but a contracted employee, or the pharmacist or whatever. And then you actually have to take action if you're not getting your money's worth. So one time, it was in 2004, and it was right when Joint Commission came out for the first time with the medication management standards, which I love, by the way. It was at the same time that they rewrote, CMS rewrote all of the CMS sections on pharmacy, and it was the year that USP 797 came out, which was a federal law. And so when I went to meet with a pharmacist, I said, we need to do a gap analysis. We need to implement these into our process, into our policies. And at first, the company, and I waited 3 months just assuming our pharmacists knew that, and because, again, we'd hired this company to manage them, and they were supposed to make sure they were aware of all these new things, and they weren't. And so at first they said, well, you can't use those our policies. And we're like, no, these are our policies. And second of all, we cannot have policies that violate Joint Commission, CMS, and federal law. So either you work with us or we have to terminate the contract. So again, you've got to determine what you're going to do. Now, we had an amazing pharmacist and we loved him and we didn't want anything to happen. So finally they said, okay, yeah, we'll work with you and, bring these up to speed. And the board, if you do have to, make changes because something wasn't correct, the board has to make sure that any corrections were sustained. In this case, that they were. And I love the Joint Commission. They have more detailed contract management. We'll talk about this in leadership. I love the leadership chapter. I've written three books on that. On slide number 32. The board needs to make sure that contracts are performed in a safe and efficient manner. So I always put that in all my contracts because, again, it is a requirement. And, for example, again, they're talking about indirect arrangements may take into consideration formal contracts, joint ventures, informal agreements, shared services or lease agreements. But the bottom line is when they talk about whether we call it a memorandum of understanding or an agreement, the bottom line is we lawyers just like to call them a contract, and the bottom line is they have to be in writing. And they have to, again, when I was recently at a hospital and I was looking at their QAPI plan, and I said, you don't have in here, in your QAPI plan that you do a review of contracts. And so you could, be cited by that. And again, I wanted to see, do you have a list? Do you have someone in charge like what I showed you earlier, where we identify what the contract is, what it does, what are the performance indicators, and then we had the person who's supposed to be evaluating those to make sure that that is being done. And it's the board's responsibility. Now, the board, as a practical matter, usually relies on us to be the clinical people because some boards are farmers or bankers or teachers or whatever. They may not be, healthcare individuals, so they rely on us, but the board is ultimately responsible to do that. So here's an example of a hospital that contracts out MRI, their MRI imaging. So if you were going to do, and every year I do a 2-hour program on all the MRI standards. CMS rewrote them all in July of 2015. CMS, or Joint Commission, came out with the first diagnostic ones on MRI. So we would have a whole list of things. So we want to know the number of times that a ferromagnetic object was taken into the room because the MR tech, too, should be monitoring that. The number of burns, which are 70% of all adverse events, hearing damage, so they give the patient hearing protection because that's 10% of all the adverse events, and MR safety. Compliance with the required training. The American College of Radiology puts out the MR standards. Completion of the MR screening form. requirement to be credentialed. So again, there was a whole list of things that we put in. We would put in the contract so that we would evaluate them. And again, we would do a 6-month evaluation informal to see that, you know, we're not having problems, that everything is on par. And then at the end of the 1 year of the contract, we would do a formal evaluation of the contracted services. And again, you want to make sure you're reviewing in your QA plan that you're making sure you're hitting all of the contracted services. Again, we're primarily talking about joint ventures and again, patient care contracts. And you have to have a list of all your contracts. You want to have them in one place. As I mentioned, when I went to a hospital, they didn't have a master list. They were all over the place. And it was a good time because I was implementing all of the HIPAA privacy and the BA contracts. So that was a good time to, you know, put them all in one place. And when you're reviewing the contracted services, again, you have to keep in mind because any hospital that accepts Medicare or Medicaid has to follow these standards. And I used to add a provision to all of my contracts that said that you agree to follow all the hospital conditions of participation. And again, we were accredited by the Joint Commission. There are 4 accreditation organizations, whoever you are accredited by. And then these, I used to do a lot of review checklists, and I would base these specifically on individuals and what contracts that they were doing. But in the contract, we would always put in there when the contract can be terminated with cause or without cause. So, you know, if all of a sudden, you know, the organization, you know, doesn't want to do, you know, the company we've contracted with, they decide they don't want to do lithotripsy, or, you know, the security company decides that they're going to fold and they're not going to, you know, provide security to the hospital anymore, then there's a clause that, you know, they can terminate without any cause. Or the same with us if we just decide we want to go with another company. Indemnity, I never would sign a contract unless it was a mutual indemnity. And I had people in my organization before I got there that were signing all kinds of things, agreeing to indemnify the other party, which were inappropriate. So indemnity, for example, in our ED physician contracts, and they were contracted employees, that if the doctor got sued for something that the nurse or the hospital did, then, you know, we would assume the case and pay the judgment. If the hospital got sued because of what the ED physician did, he was an independent contractor, they agreed to indemnify us. And then, you know, they had to have liability insurance, and it had to be from a company that we knew was going to be around and not go belly up. And then, again, we would put in the quality provisions, and so that this is an example. And then we would also, this is just a different tool for evaluating. We would evaluate both, let's just take the example of our pharmacist. You know, we would also have a tool that, you know, do they come to work? Do they show up on time? Do they call off and let us know? You know, do they follow our HIPAA privacy? And we would have one that was, you know, kind of based on information for all our employees. And then we would have one that would zero in on, you know, are they following the contract? You know, is the service, you know, are there any problems with that service? Do they issue the necessary material within the time frame? And so, and I got smart when I started doing, doing the evaluations, because, say, for an example, that the ED physicians would do their own QAPI, and they would give us a copy of that on a monthly basis. So again, when we would evaluate that, we would have that person bring that information to them. So for example, with the pharmacist, they had to be ACLS certified by April. So when we met with them in June, they needed to bring the ACLS card. And we said that the pharmacist had to attend the monthly medication management team meetings and was also responsible for putting together the resources with the team. And we had a medication management champion on every unit, and every 3 months they would hit everybody in the department. So they would bring, the pharmacist would bring copies of the minutes so I could see where the pharmacist was in attendance, and yes, that there were 6 meetings scheduled during that time. And the pharmacist, one of the performance indicator thing, what they had to attend the monthly medical executive committee. So again, they could bring minutes of the meeting so I could verify that yes, the last 6 months they have been attending those monthly meetings. And so again, do they inform staff again of work hours, or if they're unable to complete an assignment. So again, these are all just tools that we would use. Were there any problems? If there were, what actions taken, and were they resolved? And then I used to always do a lot of checklists. So you do want somebody in your hospital to be the person that's going to review those. So in many hospitals, I was in-house legal counsel, so I did contract review. In many hospitals, it's the risk manager who reviews the contracts. And then, do you have a policy requiring that all your contracts be submitted in writing? And that's important. And whenever I would do a contract with somebody, I would always have them send it in Word, and then I could review it and make changes, and then they could be tracked so they could see what changes. And do you have a policy on signature authority? So when I got to this hospital, everybody was just signing off on contracts, and there was no signature authority. And signature authority to enter into a contract, it might be where maybe the department directors have $10,000 of authority. If it's more than that, they have to go up the chain. Maybe the chief suite has $50,000. Maybe the CEO has $100,000, and anything over that goes to the board. So whatever it is. So, you want to make sure that people are, and when I used to do contracts, I used to say that the person signing that is warranting that they have, the authority to bind the organization. And then you want to make sure the correct corporate name. So one time a company was wanting to start a hospital in town, and they were going to build it, and they had sent me a contract and wanted me to be the president and CEO, which I didn't accept the contract. But when I looked at the Secretary of State, they didn't have the name on the contract that was the same name that had been filed with the state, with our state. Is there, and this is important, in contracts, we always put in there that if we're going to make any changes in the contract, it has to be in writing, because you don't want someone coming around and saying, oh, yeah, we signed that written contract, but then we had an oral contract that changed it. And every contract, now if you're dealing, I'm in Ohio, so if I'm dealing with a telemedicine group that's in Ohio, or a group to provide psychiatrists or whatever, and they're in Ohio, that's going to be easy because we're going to say it's governed by the laws in Ohio, because case law in contract management can differ. But if I get a contract from somebody outside of the state, obviously they want to have it follow in their state, and I want to have it follow in my state because I'm more familiar with my state laws. And also, sometimes we might require the contracting party to carry workers' comp or general liability. Maybe we're having them build on a addition to the hospital. Sometimes we've actually been asked to be named as a named insured. So we used to have the helicopter come in. In fact, the helipad was right above my office. And so we, sometimes they would come in and pick up patients that weren't even hospital patients because they weren't a level 1 trauma. And so, they had an insurance policy, so if they crash against our building and our building burns up, that we are insured, and we insisted that we be named as a named insured. And so these are all, again, examples of, proof of insurance. So again, the pharmacist and the pharmacy company, they had to show us proof of insurance, those types of things. Do you have a method to centralize all contracts? Do you make sure there's periodic review? Is there a system to flag termination if you have an electronic system? Because you want to know, we used to have a tickler system, and it would tell me that this contract is 3 months out, and we're going to have to negotiate that. And then have a contract policy. When I got there, the hospital did not have any contract policy, and the contract is also going to say things like, when are you going to send contracts to outside counsel? So physician contracts, we actually had somebody in our hospital that was a physician recruiter that actually did the physician contracts and was very up to speed on, all of the fraud and abuse and making sure that they didn't violate any of those. Construction contracts, we definitely would send those out if we were going to do, build on a new wing or whatever. Education contracts, I actually did all of those, and we also provided sometimes, we had a lot of education contracts. We had a lot of residents and students and student nurses and student lab techs and whatever. And so sometimes they would send the manager the contract, And we did allow them to sign it, but what I did was a list of things that has to be in there so that they could review that. So those are some examples. Now, a lot of hospitals are outsourcing compounding of pharmacy things. And what happened was, I don't know if you remember the fungal meningitis cases, the NECC. It was a company on the East Coast, and they had a dirty pharmacy. In fact, they were actually using falsifying records and using expired ingredients and ignoring mold and all kinds of things. So a federal law was passed, and the OIG actually issued this memo on 55 things that every hospital should be doing. And so they're really focusing in on this pharmacy regulations, including the outsourcing. So they may ask to see your contract. They may ask to see have you gotten data from this pharmacy that is doing your compounding to make sure that they're not a dirty pharmacy. And they prefer that we use a pharmacy that is on the FDA's list, because the FDA will go in and periodically inspect them. So again, this is a new day. So this was the 55 things, and every pharmacy director should be aware of these, and all the pharmacies should be aware, because these are the things that they're going to ask. So you'll see the second one up there. Does the surveyor review the hospital contract for your outside compounding pharmacies? And then this is the 55 things, and this is why they rewrote the pharmacy standards. And they also trained all 4 accreditation organization surveyors, and also the state agency. So for example, the regional office might ask in my state it's the Department of Health to go out and do an assessment or a complaint survey, and they have training because this report criticized the surveyors for not doing that. So that's why there's so much activity. So that is tag 83, 84, and 85, which are the standards for hospitals. Now, we have about 1,280 critical access hospitals in this country. And if you don't know who a critical access hospital is, they are 25 beds or less. They have to be 35 miles away from the next closest hospital unless there's mountainous terrain or secondary roads. And on April the 7th of 2015, they issued these 92 pages of standards out of the 281 pages were amended, and they added a contract management section from tag 286 to 289. But with critical access hospitals, again, you want the same things. You want to have all the contracts in one place. You want to have a log. Electronic log is better. You need to have the performance indicators. You need to make sure that you're monitoring those indicators. You need to make sure that a list goes to not only them, we haven't talked about this yet, but to the board, but also it needs to go to the medical executive committee, and I'll talk about that in just a second. And of course, smaller hospitals actually tend to do a lot more contracts than the bigger hospitals, and they can have contracts for outsourcing lab tests, radiology, so in the evening, teleradiology. They may outsource diagnostic tests. And so again, in the document review session, the surveyor is going to ask the critical access hospital, what services do you contract out? So again, they want to see that one list. Oh yes, we use the Red Cross for getting our packed cells, or whatever it is that you're doing. And the surveyor is also going to make sure that you're verifying licensure for any contracted personnel. And even though CMS doesn't mention that between tag 83, 84, 85, they actually are doing that for all hospitals. And so if you have a neurologist who's reading certain reports for you, and you've contracted that out, you still need to verify licensure. And in most states, it's pretty easy. You just go onto the state medical board and put in their name, and you can print out as primary source verification that indeed it is licensed. And the surveyor is also instructed to look at telemedicine contracts. CMS in Appendix A has 6 different tag numbers about requirements for telemedicine, and the critical access hospital has 4. But if you look at why hospitals are cited for telemedicine, the main reason they're cited is because the contract doesn't have the provisions that are required to have it in there. So, for example, if I'm a small critical access hospital in northern Minnesota, and we have did a study and found that 25% of patients that were suicidal were getting discharged from the ED without even a consult, and we're concerned that that's a patient safety and risk issue. The medical staff agree and tell the board to get a contract, and so now you're contracting with a group of psychiatrists. And if you contract with a hospital and the psychiatrists are employees, they just call it a DSH, or a distance site hospital. If you contract with anyone other than a hospital, we just give it a new name. We call it a distance site telemedicine entity. And so you would need to make sure that when they're credentialing and privileging, they're following all the CMS guidelines. The contract has to say that you have a right to rely on them. They will send you all the credentialing and privileging information. You can put it in a file. And then if you get notice that there's something wrong, so say the ED doctor calls you in risk management and says, hey, that new radiology group we started using last week, we're having some issues. Well, what's going on? Well, yesterday they missed a clear pneumothorax. Today they missed a hemothorax that was clear. And again, there's a communication. So all of that has to be in the contract. And the main reason why hospitals are getting cited for telemedicine is because the contract doesn't have what's in it. Also, it discusses contracts in the maintenance department regarding equipment testing and inspection. So, for example, one time I managed several departments of a hospital, and I had this, I came to this ED and I thought, a YAG laser, why, they don't do cataracts, why would they have a YAG laser in the ED? So I couldn't find any information where it had done the preventative maintenance check. We always had a lime green sticker to show that maintenance had checked it off. So I called the director of facility services and maintenance, and I said, can you send me the record of this equipment and the maintenance? And he said, Sue, we haven't been doing any maintenance on that. We haven't been calibrating that. We didn't even know you had that piece of equipment. And in fact, if you want to continue to have it, we don't even have anyone who's qualified to maintain that equipment. We're going to have to get the biomedical engineer in the next county. Well, nobody had ever used it, so that was a good thing, so we just got rid of it. But there is a section in there to make sure that people are qualified to do the equipment, and if you outsource it, again, you have to make sure. This is the Critical Access Hospital website. Again, it's Appendix W, and the last time it was updated was December the 16th. So you have to have an agreement to have one or more providers provide services, and again, you have to have at least one doctor to be able to run a critical access hospital. Obviously, most of them, there are multiple doctors. And this is kind of interesting. If you refer patients out, you actually have to show that doctors are accepting the patients when they're referred and given an appointment and actually seen. So what they're talking about here is our on-call physicians. So if somebody came in and they had a fractured tib fib or a Colles fracture, and we put a splint or a cast on, and we would give them the name of an orthopedic surgeon to follow up with. In some critical access hospitals, they may not even have any orthopedic surgeons on their staff, but there's one in the next city or the next county that will take their patients for follow-up. So it's not fair that today or this week you sent them 10 customers, 9 paying customers, and 1 non-paying customers. So they have to agree to accept the patient, whether or not you have a contract or not. They basically have to agree to see those patients for that particular problem. Now, if they're being seen for a Colles fracture and next week they break their tibia, they don't have to see them for that unless, again, they're accepting all the hospital's patients for that. And then a lot of times the critical access hospitals do outsource a lot of their lab tests, so we would have a list of what lab or diagnostic tests are not available and that they would contract out. And again, they want the surveyor to look at any contracted area on any that's under your provider number or CCN number. So it could be where you're outsourcing the MRI to this particular place. And of course, some lab tests have to be immediately available, CBC and things like that, so we can assess our patients. Again, this is just talking about the lab because, again, critical access hospitals also often outsource, some of their lab tests. The same is true of radiology. You need to make sure that there's, for example, a lab that the results come back, that the results are on the chart, and the same if you outsource radiology, that you get a copy of the report. And be very careful. We had some problems with, I was at a board meeting with on a board. I was on a board for emergency medicine services, and we had about 10 ED physicians at the table, and we started talking about this. And 4 of them said, oh yeah, this one organization that was doing teleradiology, they got a preliminary report that was normal or negative, and then it was changed later. So again, you want to monitor that for contracted services and keep both of those reports, because if they tell you there's no fracture and then later, you know, you send the patient home and then they say, oh yeah, there was a fracture, or you know, they say, oh yeah, at normal, you know, X-ray, and then you find out, well, there's free air or something, that can be a problem. And the same thing, you can contract out the director of dietary or contract out the dietary service. But again, you still have to make sure the needs are being the nutritional needs of the patients are being met. So I was working with a hospital last year, and they had made a decision that they were going to outsource their dietary and running of their dietary department to a company that did that. And so we did provide, there's a whole section in the CMS manual on dietetic services and what had to be complied with. And so we did schedule the director for a 2-hour program where we went through all of the CMS and Joint Commission standards and our state law requirements for dietary services. Tag 291, again, just like all hospitals, you need to keep a list. You need to have everything on the list. You need to update it. If you add something or take it off, that's why electronic is good. And the CEO is actually responsible to run the whole hospital, including their responsibility for contract management. And also it includes services provided directly to the patient and services that are related to patient care. So again, housekeeping, instrument cleaning and sterilization if you outsource that, laundry, pharmacy services, lab. So you can see that that's kind of a shortened version of what is in Appendix A for critical access hospitals. So now let's look at the Joint Commission management standards. The Joint Commission has their standard that's located in the leadership chapter. They completely rewrote the leadership chapter in 2009, and then with Hospital Refresh, when they made 225 changes to the elements of performance, they made a lot of changes in leadership 04, 03, 09. And also July 1 of this month, they made a lot of changes and actually a lot of different standards. And so Joint Commission says, yes, hospitals enter into lots of contracts from provider groups and diagnostic centers and vendors and employment agencies and other business partners, and that we need to have a system to manage those contracts. And it's also necessary to save time, save money, guard against liability exposure, reduce the likelihood of conflict and litigation. So in fact, I took a year of contracts in law school. All lawyers are required to do that. But we get these green books, which are basically cases in our state. And in 1 year, there was a hospital in town, and I saw 4 cases where physicians that had contracts were ending up suing the hospital. So in one, just because, you know, so a hospital had a contract to have a sleep lab, and this person was going to have exclusive rights to, you know, to read those tests or whatever. Somebody else isn't new at the hospital comes in, and I guess they thought that they shouldn't be governed to contracts by somebody who wasn't there any longer, not realizing that, yeah, you are. And in all these cases, the physician won those contracts. So they wasted money, time, and then right after that, a friend I used to work with for 8 years at the Ohio Hospital Association actually went there to, you know, they actually hired 2 attorneys in-house to do all their contracts because they realized that they, again, had a lot of liability exposure, that was conflict, litigation. Again, do you have all your contracts in one place? Do you have a review process? And again, you need to keep in mind the CMS requirements, Joint Commission. Again, 80% of the hospitals are accredited by the Joint Commission. Now, this is a survey that of 13 hospitals that were accredited by the Joint Commission. I'm on a listserv, and this was shared with those of us on the listserv. This was done last year. So they were surveyed under the SAFER matrix, and the issue was, did you have effective evaluation of the contracts? So basically, hospitals were cited for not having, again, QAPI related to the contract. They were asked, these 13 hospitals reported that they were asked to see contracts to make sure there was an annual review. Surveyors wanted to see a list of the contract, and again, they would pick some out to see if that review was done. They wanted to see who the contract owner was. They wanted to see the quality metrics that you were using. How did you monitor? How often did you monitor? Were they all in one place? So these were comments from some of those hospitals. And a hospital had agreed with a vendor on what the metrics would be. This had to do with outsourcing and medical and engineering, but it wasn't in the contract. So again, you can add that as an addendum if somebody forgot to put that in there, and just, they sign the contract and say, okay, we agree to, Appendix A is hereby incorporated by reference, and basically includes a list the performance indicators. One hospital said it was the most rigorous contract review of her career, and she'd been doing it for 40 years. Many of the hospitals reported their contracts did not have performance metrics, and there were problems with contracts of lithotripsy, dietary, dialysis, a lot of dialysis, and equipment contracts. So that was pretty interesting. So if you look at how the leadership, and again, I love these leadership standards. I've written 3 books on the Joint Commission leadership chapters standards, but there's kind of like, if you look at a piece of pie and it's in 4 sections, there's a section on leadership structure, how you're structured. For example, you have the board, you have the CEO, the COO, the C-suite, and then the leadership relationship. And the 3 leadership groups are the board, the medical staff leadership, and the CEO and senior leaders. I kind of call it the leadership triangle, and how these 3 relate to each other. And for example, a couple years ago, CMS rewrote all the medical staff roles because it really is important that the medical staff and the board have good communication and good relationship. There's one on culture. I love this, and performance expectations and systems. 78% of all the errors that occur in hospitals are system-related problems. And then the 4th one is the more traditional operation, and this is where the contract management standard lays. This is one of the books that I published on that has a chapter on contract management. So what Joint Commission is saying, the same thing as CMS, is we don't care whether that pharmacist is your employee or a contracted employee. We expect the same level of care. So you can't say, oh, no skin off my back. Again, the patients have to get the same level of care. Whether, the person who reads the EKGs is your employee or a contract cardiologist, they have to be read appropriately, and they have to be timely provided to the provider. And just like CMS, the leaders have to make sure that they're provided safely and efficiently, and you've got to have a policy to do this. And this means that your leaders have to be actively involved in not only negotiating and getting the contract. That's just the first step. But then you want to make sure you're getting your money's worth. So are you approving those contracts? Are you monitoring to make sure that you're getting what you should be getting? And I'll give you a couple more examples here in just a second. So we would have liked to have hired our own physical therapist who was specializing in hand injuries for children, but we couldn't find one. So our hospital entered into a contract with the Children's Hospital in the next county. And so we'll use that as an example of, how do we evaluate that individual to make sure that we're getting our money's worth. So are the patients being seen promptly? Are the physicians getting a report regarding the plan of care and how the patient is doing? Again, those are some of the things that we would expect. And Joint Commission, if you look at their standards, they are not specific about what you have to do to monitor them. they did put it in an FAQ. In fact, interestingly enough, they originally put it in the standard and then pulled it out of the standard and put it in the FAQ. So I actually thought it was better in the standard, but at least you know, we know what the steps are. And so the bottom line is that we're free, as hospital leaders, to develop an oversight system that's appropriate. So if we're going to do, I'll give you an example here in just a second. So we'll use the example of the hospital that had hired the pharmaceutical company to run the pharmacy, and the director is an employee. And again, we'll use the example of the part-time physical therapist who specializes in pediatric hand injuries, and again, she was an employee, and she would come 2 days a week to our hospital. Now, Joint Commission is very clear that these standards apply to contracted services, and again, that are related to patient care. Now, remember what CMS said about joint ventures, something like that, although most of the time they're looking at the same thing. They're looking at patient care contracts. Again, they ask about linen. Now, snow removal, there are, and what Joint Commission says, there are other things that you want to look at contract, but those are reviewed at other standards, not at the contract management standard. They often ask about linen service. So again, you might want to make sure that they are accredited by the Healthcare Laundry Accreditation Council. We made sure that you know, we had adequate linen and it was delivered and all of those types of things. Contracts for consults or referrals are not subject to the contract management standard. Again, they're somewhere else. And so regardless, as I mentioned, contracts may be evaluated at other standards. So the performance of the contract needs to look at basic principles of risk reduction. Are these contractors providing safe services? Because safety is important. Are they competent to do what they're doing? The contract should, again, show what performance improvement, what we're measuring to make sure that the job is being done, and I'm going to give you some examples in just a second. So again, it doesn't prescribe specific things, rather it gives us some options on how to review these contracts, and sometimes we'll use several of these. So let's talk about the physical therapist. So first of all, the director of rehab did a direct observation, popped in a couple of times to watch this contracted employee. And then the American Association of Physical Therapists tells us what should be documented in the chart. And by the way, CMS, it's the very last one in the 528-page manual, also tells us what has to be in the plan of care. And then we can audit the medical records to make sure that those documentation requirements are there. We could review incident reports to make sure that, you know, when she's working with kids, they didn't fall off the table or didn't have some type of sentinel event. We can obtain input from staff and patients. So we did query our pediatricians and our trauma physicians who were referring patients, and how does this go? Oh, this is great. Our kids don't have to leave the community to get there. You know, they had a bad fracture of the radius and ulnar, and this person is doing the ultrasound and the care of the, you know, the physical therapy of the wrist, and we get reports back timely, and so they're saying it's working really well. We also send the list every year to our medical executive committee, and I'll show you why. And then, again, are there any risk management activities? Was there any problems related to that? And you can review information, again, from the contractor. So, again, that's also accredited by the Joint Commission. And, again, we'll look at the data. We'll look at the indicators in the contract. Again, the reports that are submitted by the individual. So we would have, you know, information like, you know, did they cancel any appointments? You know, was there, you know, was the plan of care on the chart for every one of these people that she was doing care for, those types of things. And then Joint Commission has a definition, and the bottom line is no matter what you call it, it's a contract and has to be in writing. So in writing is the important word on this one. So the standard is under LDO 40309 is that care and treatment provided through contracts have to be provided safely and effectively. Again, that's right out of CMS, out of the CMS COPs. So EP number 1, or element of performance number 1, is that clinical leaders and the medical staff have the opportunity to provide advice about the source of contracts. So every year we would send a list, that list I showed you earlier, of all the services and what it was to accomplish and what were the performance indicators and was it met, and if it wasn't met, what we did about it and who's the contract owner. But we also sent those to our medical staff, and we'd say, hey, you know, we have that new adolescent psychiatrist. How's that working? Oh my gosh, it's great. Our kids don't wait 3 months to get in to see an appointment. You know, this person gets them in right away. They provide us a follow-up report. It's fabulous. Or, you know, how's our Red Cross doing? Are you getting the pack sales that you need when you need it? Oh yes, we're getting everything that we need, no problems. And so the nature and the scope have to be provided. So this scope is, the nature of this contract is for to provide MRI services, and again, we would describe that. And then contracts are approved by the designated leader. Again, I call it the contract owner. And then we set expectations. So again, we sent out in the pharmacy one that you have to make sure that you're in compliance with all the Joint Commission, CMS, COPs, and our state pharmacy laws, and that you have to notify administration within a time period, 2 weeks, of any new laws that are going to be in effect for hospitals. And then you need to make sure that these are implemented and reflected in our policies. And then you have the responsibility for making sure that all of your pharmacy staff are educated and that you communicate with nursing or other people that need to know that. So that you're going to be ACLS by April. So again, we had all of these expectations or performance indicators that were in the contract. And then this is just talking about, they have some proposed changes, the Joint Commission does. So I'm going to talk about this in just a second about telemedicine. And then we communicate those expectations. So remember when I talked to the pharmacist, and I said to him, because he actually had been there for a few months before I came, and I said, do you know what your performance indications are? And he said, no. That's actually a Joint Commission standard that we as leaders need to make sure that people know what they're going to be evaluated on before they're going to be evaluated on. And so, for example, one of the contracts that I did with the emergency medicine group said that they had to, you know, have 2 hours of EMTALA training, and they had to be able to pass the hospital's EMTALA test, which is kind of important. EMTALA is a federal law, the Emergency Medical Treatment in Labor. The penalty doubled and then had a cost of living increase. It's almost $105,000. We've seen over 4,000 deficiencies, and then last year the OIG actually amended. So we really wanted to make sure that everybody was up to speed. So again, when I met with the director of the contract and I said, you know, during this meeting, I would like you to give me a list of, you know, all of the physicians and which ones have, you know, taken our test with an online test. They could take any time, and that they've had the 2 hours of education. So when he met with me, none of them had done that, and I said, okay, so when we meet in 6 months, how are you going to make sure, you know, that we don't show up and I find out that none of them have had that, because now you're in breach of the contract? Okay, well, I'm going to have my assistant who's going to send out an email and tell everybody they have 60 days to do it, and she's going to follow up with anyone that doesn't do it. And they don't get their paycheck if they don't do it. I said, well, okay, whatever you do, just make sure it gets done. So again, we need to communicate in writing, and then we need to evaluate to make sure that it was done by the time we meet. So again, our pharmacist is going to manage the monthly medication management team. They're going to attend all of the MEC meetings unless they, and in the contract we had, if they were on vacation, then we would, you know, they'd have to tell us, well, I have a meeting that week and can I send the assistant director? And the answer to that is yes. They have to ensure privacy and confidentiality. They have to follow all state and federal laws. So again, we put all of this in here that then we would monitor those individuals. So here's an example of a hospital in their dialysis contract. They analyze the water quality, equipment maintenance, if there are any complaints from the patients. They do a chart review to make sure that there's been hepatitis screening, and the post-treatment handoff to the RN has been documented. They have to document their observing the catheter site. They have to complete the contracted staff competencies every year. And then what happens if you don't, if they're not meeting your expectations? So are you going to do increased monitoring? Are you going to terminate the contract? Are you going to renegotiate? Remember when I mentioned in 2004 that if they didn't come into compliance with the federal requirements of USP 797, the Joint Commission Medication Management Standards, and CMS rewrote all of the pharmacy standards, then we wouldn't have had any choice but to terminate that or apply penalties. And I really like to write that in my contracts. I do it in my contracts when I've had work done in my home. So I want you to build a sunroom on. How long does it realistically take you to do that? 2 weeks. Okay. Well, I'll tell you what. I'm going to give you 3 weeks in the contract. And if you get done, early, you get a bonus. But for every day past 3 weeks, because I don't want them to start my job and then not show up for a week and go work on some other job, then you're going to pay me a $50 a day penalty or whatever. So the same way with contracts. And then when contracts are renegotiated or terminated, the continuity of patient care has to be maintained. So one time when I went up to a hospital to manage several departments, this was back in the 80s, including the emergency department, as I'm walking in on my first day I'm supposed to go in orientation, the CEO greets me and he said, "I'm really sorry. I realize this is your first day. However, I have to tell you that yesterday we put the emergency department physicians on notice that we're not renewing their contract, and so you have 31 days to find a new emergency department group." So, of course, I found a group that came up, and so the old group, they stopped on July 7th at midnight, and then at 12:01 the new group started. And the same thing, because I can't not have emergency providers to care for patients. And the same thing with radiology. If you change radiology groups or pathology groups or anesthesia groups or whatever. EP number 9 was deleted as of July 1st of this month. And I'll show you the new language they want to put in there. And again, if we reference something or send up, lab things outside, we need to make sure that they are also, have a CLIA, a clinical laboratory improvement, that they are licensed for that. And then EP 23 has to do with telemedicine. Again, they may ask about your contracts. So this is all the things I was talking about. So I'm the originating site. I'm this small critical access hospital in northern Minnesota, and I'm going to contract for the radiologist at the big hospital in Minneapolis, and they're the distant site. And then, again, I had to put in the contract that because we are a Medicare provider hospital, that they have to agree to credential and privilege according to the requirements that are set forth in the Medicare COPs. And then again, the board sends a contract. They approved it. I kind of already went over this. We can rely on that information. Again, most of the provisions of why hospitals are being cited, 6 tag numbers in hospitals and 4 in critical access hospitals, is because you don't have all the things in the contract provision. And then the board of the big hospital grants privileges to the distant site, which is again the small hospital and critical access hospital in northern Minnesota, to make sure. So these are some examples of how to comply with these standards. Have a contract review policy. Determine who is the contract owner. Determine who has authority to sign. Remember we said, can the manager sign? Does it have to be the C-suite? Does it have to be the CEO? In big contracts, it might be the board. Have a contract management log. And I won't go over all of these. Some of them, you know, obviously we're duplicating. Make sure that you send a list of contracts not only to the board, and you have that in the board minutes, but also to the MEC. Again, if you outsource any lab tests, make sure they have a CLIA license. And again, you want to evaluate your contracted employee just like you would a regular employee. You want to monitor patient satisfaction. So when we first started getting mammography, there was a hospital that had outsourced it, and the CEO got a call from one of the physicians who said, hey, this patient came into my office today. They have a very suspicious lump. I called to get a mammogram done right away, and they gave me an appointment for 6 weeks. And that's never going to work. And so the hospital said, fine, we'll call them, we'll take care of this. And the hospital then took over their own, you know, had their own mammography unit. Again, I've developed a lot of tools that the different managers could use. And again, we want to have language in there that you're going to comply with all the Joint Commission, federal, state, CMS requirements. And I always wanted to have a contract management committee. I have a friend who's also a lawyer at a hospital, and he had gotten a contract management committee. And how cool is that? Because you know, you could take and teach this group of people all. I mean, you know, I took it for a year in law school, all the things that could happen and what you want in, and then that way everybody would know what you're doing. You could, you know, monitor those contracts. So I was always envious because he had a contract management committee. And then I mentioned that Joint Commission is going to consolidate contract management. They're going to take 4 elements of performance. They're going to put them into a new element of performance number 4, which the new one, at least the proposal, would mean that leaders, including the board, have to monitor contracts by doing the following: setting expectations. This is the website if you want to go take a look at it. Again, you would communicate the expectations in writing, evaluate the contract services in relationship to what we expected to get done. The board has to make sure that they're all done. So these are all current provisions. It's just that they would reword them. And we see a trend to where they would consolidate and get rid of a lot of elements of performance. They would also delete EP number 9. Actually, they did delete EP number 9. They said that was in the proposed ones, but if you look in the July ones that came out, they already did it. And then they're actually going to add a new EP 26 and 27 and delete the medical staff 1301-01. So again, you would verify credentials, grant privileges, again, use that information. And part of this was, again, looking at telemedicine, and Joint Commission changed the standards 3 times in an attempt to try to meet what CMS was looking for. Again, you've got to get a current list of the licensed independent practitioner privileges from the contracted organization, again, for telemedicine. So we want to have psychiatrists, or we want to have, you know, their dermatologists be able to read these. You've got to document the method. And again, whenever you see a Joint Commission standard and it says DS behind it, that means deemed status. The VA hospitals do not have to follow the CMS COPs because they don't get reimbursement from CMS. But some of the VA, most of the VA hospitals are generally Joint Commission accredited. So when you see DS, that means that Joint Commission implemented it because it was a CMS standard, and the VA hospitals don't necessarily have to follow that. As I mentioned, for telemedicine, there's 6 tag numbers for hospitals and 4 for critical access hospitals. And these are the tag numbers in case I had somebody call and ask me, well, what are those telemedicine tag numbers in CMS? So here they're listed. And EP27 is that the hospital sends information to the provider site that's relevant as far as quality of care. So again, remember, if we got complaints that, gee, they missed a pneumothorax or a hemothorax, we would communicate that because they're doing the periodic performance evaluation. And then there's a couple other standards that mention contracts. So marketing material has to clearly be accurate, even if you outsource it. So it's funny, I had a friend who was looking at Groupon and bought one for laser on her legs, and it said, oh yeah, they use a state-of-the-art laser. It is the one that is top ranked by, you know, and so when they sent her a contract to sign, she just copied and pasted that into the contract. And they go, we're not going to sign that. And she said, well, isn't this the safest laser, and et cetera? And they go, no, we didn't do that. You know, they must have done this in their marketing material. Well, you know, hospitals can't say, oh, our marketer did that. Gee, the marketer said that we have the safest, you know, rate of, the best rate of cancer survival than any hospital in the country, if that's not true. So they would cite you on that. And then when you, if you have a, say, for example, you've done your assessment of the community assessment, and you said, oh my gosh, you know, we have a terrible problem with the shortage of behavioral health beds, and our emergency department is having a lot of problems with boarding of patients because we can't get them to a bed and crowding, and so that's a problem. So the hospital agrees to open up a 10-bed behavioral health unit. So you can either have your hospital run it, or there's groups that come in and run behavioral health hospitals. So again, you can decide that. And the same thing here. So if you're going to do it, are you going to run it yourself, or are you going to contract out that service? And again, the scope of document should reflect the types of services that you do. And the scope of service, we used to call ours a provision of care. So every year we would update this. So if a surveyor walked in, she could say, oh, you have a 10-bed behavioral health unit. Oh, you have an 8-bed ICU. Oh, yes, you have speech pathology and it's an outpatient department. So these are some questions that Joint Commission has asked about contracts. How do you make a decision about where to purchase drugs listed in your formulary? How do you decide what company to pick that makes floor cleaner that's used in patient rooms? Well, we use one that is going to kill the things that we see on our floors. We use one that doesn't have a bad smell so that patients don't, you know, we tried one earlier and it really made our patients nauseated. What decisions process did you use to select a company that supplied canned goods to your dietary department? Well, we buy from a commercial distributor. We've never really had any problems with recalls. Things are really fresh. We have good comments from our patients on the tastiness of our food. How do you choose a company to do pest control in our state? You have to be licensed. We followed the CDC guidelines on pests, you know, reducing pests in hospitals. And then also, this is the FAQ. They have some FAQs on contracted services. So they say, what does a contract service apply if the group you're contracting with, for example, the Children's Hospital we contracted with, was also Joint Commission accredited? What are the responsibilities related to services by your contracted organizations? And how does the HR department verify the files? So this is the one that I mentioned where we gave you all these examples about auditing and directly observing. I mentioned they were in the FAQ. Initially, they had them in the standard, and then they pulled them out. And also, do the contract management standards apply if you are using someone that's from a Joint Commission accredited hospital? Yes, they do. And then what's the responsibilities? The leaders need to provide oversight to make sure that things are getting done. And again, direct observation, these are just, I wrote them out so you could see them. Sometimes the little FAQs are a little hard to see. And also, sometimes the surveyor may ask, they don't do this very often, and we put this in our contracts, that if we had a survey process and the surveyors were asking for documentation of additional information, for example, the part-time person who did hands, that the HR department from the hospital that we contract with, which was a children's hospital, would send us that information if we needed it during a survey. So that's what they're talking about here. Also, there's a contract management tracer. Obviously, the tracer just hits the elements that we went over. The surveyors, we're going to ask about the scope and nature. And one other thing I'll mention. So one time I had our health information management director come, and she had a 34-page contract that had to do with our transcription services because, you know, we didn't have voice-activated systems or Dragon at that time. And so basically, she came and people would make an appointment, and we would go through it line by line and say, okay, this is what they're saying, this is what it means, can we live with this? Okay, they're going to charge us so much per line to transcribe that, is this what you've agreed to? So it's not where there's any magic, it's just where we explain those and say, can we live with those? So leaders need to monitor contracts. Again, they're going to ask you, during orientation, which ones do you contract out, how do you monitor those, including telemedicine. And every year, sometimes twice a year, they'll update this. This is free if you go out to the Joint Commission. It's the survey activity guide. They are supposed to ask about somebody who got telemedicine services, maybe stroke services, and go talk to the patient and say, how did that work for you? The surveyor is going to interview staff, again, to make sure that you know the scope and nature of the contract, and again, that should be documented in your form. They're going to ask how your contractors were oriented. So one hospital told me that for agency nurses, non-employee nurses, travelers, whatever, that they have to take a 4-hour course that they can log on 24 hours a day. It's a computerized course. Another hospital told me that they have a packet of information in a CD that any non-employee nurse would have to take a look at. And then, again, how do you provide oversight in those individuals? Again, you want to know what QAP, what are the performance measures? You want to have them in one place. You want to make sure that you know how those are being monitored. Again, these are all right out of the Joint Commission standards. So, again, have them in one. This slide got in there twice. And then we're going to, so basically, we've covered CMS. 80% of the hospitals are accredited by the Joint Commission. If you are accredited by DNV, GL, or CIHQ, or the Healthcare Facility Accreditation Program, we have you covered because they're just a basic recitation of what is in the CMS manual. So again, we had somebody say, can you give us an example? So we'll use DNV to show you how they're, and you can get the DNV standards by going to their website. You have to just register, it's free, and then you can download the manual. So it's clear contracts should be reviewed once a year. The board is ultimately responsible for all contracted services, just like CMS. And the board, and remember that it includes joint ventures and shared services because that's what CMS says. You need to have an annual review, again, by whoever is the contract management owner. The board is responsible to make sure that we're doing the QAPI, that we're evaluating those performance indicators. You need to have a list of all contracts and, again, have them in one place. Again, these are the telemedicine requirements that are right out of CMS. And, again, if you do a telemedicine contract, the board, again, has to approve it. You've got to make sure that what is in CMS is in there, that they're going to do the contracting, the credentialing and privileging according to the CMS COPs, and that the physician needs to be credentialed and privileged. Again, it's the again, that big hospital in Minnesota, in Minneapolis, is going to do that and provide that to the little critical access hospital in northern Minnesota. And the provider or physician has to be licensed right now in the state where the patient is located. So in summary, you want to make sure that you're reviewing the contract policy. You want someone to review. I used to review our policy every year to see if it needed to be amended. You want to make sure that the policy says how you're going to monitor the services. You want to make sure that there's a list of all contractors, and not only does it need to go to the board, remember it needs to go to MEC. You want to verify, and again, we would put in all of our contracts that they had to comply with CMS, the state law, and again, whoever your accreditation organization is, and as we mentioned, there are only 4. You want to have language about what we expect you to do, performance expectations. You want to make sure that the contract log has expiration dates. Managers need to know the threshold amount that they're permitted to sign contracts. And again, I got smart, have the vendors or the contracted services issue regular reports. So they talk about, in the ED physicians, they reviewed, they do audits of their charts. to make sure that they're documenting everything, and they would give us copies of that QA/PI. You need to make sure that the contract owners are aware of those standards because we want to train everybody. Again, if you're lucky enough to have a contract committee, have a written form that you're going to evaluate contracts. And again, some contracts should be reviewed by senior leadership or the CEO or the board, depending on the amount. Again, checklists can be very helpful. I used to do these for some of the groups that were reviewing the contracts. Any concerns, and this is important, if you do have a concern about a contract, you need to communicate that in writing. So when I met with the pharmacist, and again, we sent a letter to the pharmacy contracting group saying this will acknowledge that we met today and that we mentioned that, you know, because the CMS rewrote the pharmacy standards, we need to make sure that our policies comply with them. Because of the new Joint Commission Medication Management Standard, we need to make sure that we are doing a gap analysis and that all of these are implemented into our processes, into our policies, and also that the pharmacist is required to do an educational program for our staff, and so we communicated that. Make sure there's not anything we haven't hit here. Again, having somebody in charge, a contract owner. They may ask to see the contract with a compounding pharmacy. Again, we still want to make sure our contractors are licensed, credentialed, and privileged. Again, we always had a section in there that they need to comply with state, federal laws. And we always had a requirement in there that they had to follow all hospital policies and procedures. Again, some hospitals we would get a monthly report, sometimes we'd get a quarterly report. Again, we put in the contract that if it was terminated, they have to agree to effectuate a smooth transition, so our radiology group, our emergency physician group. And then you would always have in there, again, when can they terminate without cause and when can they terminate with cause. Again, get written reports. I think we've talked about all of that. So here's an example of the HR. They would, again, we would do criminal background checks as required by your state law. Sometimes they're required to do drug screens, and we always put in there our drug screening process. So, you know, one time we had a CRNA who made a mistake, and a big mistake, and again, you know, our policy was if a mistake is made, then they have to have a drug screen. Job description, again, validating during the annual skills lab or in orientation, the training, so we would put all of that in there. So this is one hospital's process. So the infection preventionist and the infection control committee would evaluate the dialysis. Our director of environmental services and our EOC committee, environmental care committee, they took the food service and housekeeping contract. The transfusion committee took the apheresis contract. The radiologist would evaluate the telemedicine services that was used at night. The legal counsel or COO would do the organ procurement contract, the interpreter, security, linen service, and then again, MEC would make a recommendation on whether we should continue it or not. And then also, just be aware that they're really hitting hard if you're contracting out sterilizing equipment. And it's not enough to just say, hey, it's a contracted service, no skin off my back. We actually need to make sure that that it's being done and that they have an appropriate training program. And the CDC and FDA actually issued this. And I'm on a listserv. We started about 4 months ago, where those of us that do accreditation and regulatory issues, we talk amongst ourselves. And there has been quite a bit of activity, and a couple of hospitals were cited. So, for example, you have to decontaminate the equipment if you're sending it out to be sterilized. So here's just some examples of contract review checklists that you know, staffing is correct.